we'll move to the next talk, which is a very important talk. All of us battle infection every day in the ICU, more especially in the ECMO ICU. I call upon Dr. Sudha Teresa, who is our infectious disease consultant at MGM. Her area of interest is antibiotic stewardship.
Good evening all. Thank you for this opportunity. My topic is infection perspectives for ECMO. Some disclosure. So in this presentation, actually I have summarized the data from the developed countries and few from the developing countries of Southeast Asia. The source of infection and epidemiology of microbiology may differ and not exactly represent our epidemiology. The agendas are incidence and prevalence of infection, risk factors, mortality, epidemiology of microbes, inter-hospital transfer, is it safe, sepsis in VV versus VA ECMO, ECMO effect on lab, approach to sepsis, PK/PD effect of ECMO on antibiotics, and infection control. So what is the definition? Infection in ECMO. So infection occurring more than 24 hours after ECMO initiation and within 48 hours after ECMO discontinuation. What are the infection rate on ECMO? According to the Extracorporeal Life Support Organization Registry 2008, the overall infection rate is 11.5%, and the prevalence is seen more in adult when compared to the neonate. So this is from the registry of ELSO. So this shows the data where the prevalence is most common healthcare associated infection between 9 to 65%, and also the prevalence of bloodstream infection ranging between 3 to 18%. What are the source of infection? The most common source of infection which we encounter in the ECMO patients are bloodstream infection, ventilator associated pneumonia, ECMO cannula site infection, urinary tract infection, mediastinitis. Of this, BSI and bloodstream infection and ventilator associated pneumonia contributes to the majority of the infection. Prevalence, different types of infection. The prevalence in bloodstream infection, you say, it's almost same for adult and the pediatric group. It's 3 to 18% to 6 to 18%. The prevalence of lower respiratory tract infection is higher in adult when compared to neonate and pediatrics, and UTI is very minimal, 1 to 2%. Mortality, nosocomial infection increases the risk of death by 38 to 63%, and of this bloodstream infection is an independent risk factor for death by 3-fold. So this data again is a single center study where you see the infection mortality among the infected versus the non-infected. The prevalence of mortality among infected is 57% when compared to the non-infected 35%. And in other study also it's almost the same. Risk factor, the risk factor of infection on ECMO increases with age. Adult are greater risk than the pediatric. Duration of ECMO, the mean time to first infection episode, if you see, is around second week, whereas when the non-infected patient, the ECMO was actually weaned by the first week. The relationship between the ECMO and infection is directly proportionate to each other. More the days of ECMO, the incidence of infection increases. Presence of foreign devices like central venous catheter, intra-arterial lines, large bore ECMO cannula, endotracheal tubes, intra-aortic balloon pumps, catheters. This actually breaches the barrier mechanism of skin and leading to the easy penetration of microbes into the systemic system. Host factor, this study shows that autoimmune mucomyelitis presents with 7-fold increased risk due to chronic immunosuppressive therapy. Type of ECMO, VA ECMO encounters more infection, the rate of infection more in VA ECMO when compared to the VV ECMO. Cannulation technique, the cardiac surgery through the open chest where surgical central cannulation technique is performed in a VA modality has more rate of infection. The double lumen jugular cannulation associated with lower risk of infection when compared to the femoral cannulation. Higher the SOPA score, higher the infection rate, and also the alteration of the bowel mucosal barrier integrity where the bacteria translocate from the gut into the bloodstream and leading to bloodstream infection. ECMO-related impairment of immune also increase the rate of infection. Inter-hospital transfer, is it safe? Starting ECMO and transferring patient to the tertiary care like ECMO care center, then treating conventional hospital. infection control. Is it associated with increased nosocomial infection? Is it associated with increased mortality? Mode of transport, is it ambulance or airlift? So this study was actually a single-centered large study from Texas, where 123 ECMO courses were analyzed, and most of the ECMO were VV ECMO. Most common indication of ECMO were post-viral infection like influenza, polytrauma, ARDS, and then cardiothoracic surgery. Almost 85 patients were transported from different countries. Of this, 11 were airlifted. So this study shows there is no significant increase in rate of nosocomial infection by univariate Kaplan-Meier analysis or multivariate analysis in groups that underwent inter-hospital transfer compared to the group that did not. And also the data showed decreased mortality in patients who were transported. So factors which might be influencing this are like patients' underlying pathologies, cannulation practice, type of ECMO configuration, VV or VA, nosocomial infection rate at different hospitals, the strength of infection control. And also in the study that showed the bloodstream infection had longer duration of onset in transport group. There's no increased risk of respiratory infection or a short time to onset respiratory infection. Distance travel and modality of transfer were not risk factor for nosocomial infection for patients transported on ECMO. No difference in the incidence of multi-drug resistant organism between transported patient and local patients. It's microbiology. So according to the Extracorporeal Life Support Organization registry, the coagulase negative staphylococcus are the most frequent causal infectious agent, followed by the Candida, Pseudomonas aeruginosa. But the recent studies have showed the coagulase negative staphylococcus aureus have presence with less frequent incidence. So this is a table from France, where they encountered more, the source of infection were more common ventilator-associated pneumonia when compared to the bloodstream infection and cannula infection. The microbiology, the most common seen Pseudomonas in both ventilator-associated pneumonia and bloodstream infection. In media standard it's Candida, and cannula infection it's E. coli. And this table is from the study from Michigan, where the most common source of infection was bloodstream infection when compared to the lower respiratory infection UTI, and the pathogen encountered were coagulase negative staphylococci, followed by the gram negative Enterobacter, Acinidoenterococcus, and then the gram positive staph. Whereas in lower respiratory infection it was a gram negative bacillus, Pseudomonas, and Enterobacteriaceae. And then urinary tract infection is Candida. So, and the study from Qatar showed they had more incidence of Candida than Klebsiella, E. coli, and Pseudomonas, and the most common source of infection were ventilator-associated pneumonia when compared to bloodstream infection and CORTI. Aspergillus involvement was strongly associated with ECMO for respiratory support and influenza. So this is actually a data or the table from a study at Korea, where they compared the infection rate for VA and VV ECMO. The bloodstream infection was found most common, and it was more in VA ECMO compared to the VV. And the pathogen, gram-negative pathogens were, the incidence of gram-negative was more than the gram-positive, and then fungi. In the gram-negative pathogen, the most common were Acinetobacter, and then Klebsiella, Pseudomonas. Gram-positive in VA ECMO were staph, then followed by Enterococcus faecium fecalis, whereas in VV ECMO it was Enterococcus faecium followed by staph. So time of infection in veno-venous versus veno-arterial ECMO, if you see the incidence of infection and VA ECMO is more in the second week, whereas in VV ECMO it is in the third week. So in this is another comparison, like importance carbapenem-resistant pathogen, we see more in VA ECMO compared to VV. And also the inflammatory markers more significant in VA ECMO than the VV ECMO. So effect of ECMO and lab. When we are interpreting the lab in ECMO patient, we have to be very cautious because most of the lab might be affected by the ECMO, such as systemic inflammatory response post-ECMO, impairing the immune mechanism, fever. On ECMO, it's difficult to mount fever as the blood goes through the circuit and also through the thermostat. So if the patient presents with temperature more than 101 degrees Fahrenheit, it actually creates an alarm because we have to look for the source and start treatment immediately. WBC count. Leukocytes leukopenia is not a good marker in ECMO, as it can be sequestered or it can increase the count based on the foreign body effect, oxygenator and demargination. The other marker like procalcitonin CRP, if it's done together, the sensitivity is high, 87%, but specificity is still low. The procalcitonin cutoff in ECMO patients too, which increases the sensitivity to 90%, specificity of 82, with the positive predictive value of 82% and negative predictive value of 90%. It has greater value in de-escalation of antibiotic in sepsis. According to ELSO task force, they do not recommend the routine pan culture, done only when there is a significant clinical suspicion. Approach. So this table actually gives an approach how to manage a patient in an ICU or an ECMO. So when there is an sepsis and with all the sepsis marker elevated, start looking for the infection, start with all pan cultures, imagings, sending a marker like procalcitonin, and we start the empirical antibiotic based on our epidemiology or whether the patient is shock and all. And once the antibiotic is started and we know the source of the infection, we had to actually make sure that what is the source, like if the source is VAP, or based on that the antibiotic penetration and all, we choose the antibiotic accurately, and the dose and also the duration of the antibiotic is considered. And once the how to de-escalate the antibiotic is based on the cultures and then procalcitonin, and we can also stop the candidemia coverage if the beta-D glucan is less than 80%. If the patient is still having sepsis features and we do not have the source, look for the other sources, like is there any deep-seated infection, abscess, or is there is any skin and soft tissue infections, and manage accordingly, and can also present with disseminated candidiasis. Prophylaxis. According to a task force, it does not recommend the routine use of prophylaxis, and even if it is used, it has to be stopped. It should not be continued beyond 48 hours. Only in cardiac patient with transthoracic cannulation through an open chest, experts consider antibiotic prophylaxis to be accepted the choice of patient. Pharmacokinetic and pharmacodynamic on antimicrobial dosing in ECMO. The PK/PD in ECMO is actually altered because of various reasons. One is the direct extraction by the ECMO circuit. It can get absorbed or it can be sequestered by the oxygenator. The altered clearance of the drug and also the change in volume of distribution. This alteration of renal and hepatic blood flow, and the immune alteration, which increases thirst response, also alter the PK/PD. Not going in detail because I think the next speaker is going to talk about it. The infection control, the most important topic. According to the task force, following things has to be observed, like reduce unnecessary breaking of lines to keep blood gas sample from the circuit or to perform intermittent infusion. Use of sterile practice and needle-less hubs for all connection access sites. Use of chlorhexidine as a solution of choice for disinfection. Careful isolation of practice is like contact isolation if the patient is having or colonized with the MDROs. Frequent hand washing when managing ECMO patient and circuit. Adequate application of guideline for prevention of VAP, all HIZ guidelines. Oral and GI decontamination when appropriate. Early shift to enteral nutrition, use of dedicated access for parenteral nutrition. Avoiding removing unnecessary central line invasive device, and avoiding insertion of long-term IV access during ECMO like PICC lines. And antibiotic stewardship. Dr. Alexander Fleming, this is a quote from Dr. Alexander Fleming. Pardon me, I'm going to replace penicillin with antibiotic. Antibiotic should only be used if there is a properly diagnosed reason, and if it needs to be used, use the highest possible dose for the shortest time necessary. Otherwise, antibiotic resistance will develop. This is a take-home message. We require a high level of suspicion in ECMO because it increases the mortality risk. The timeline of infection important when a person VVM versus VA ECMO. The common source, rate of infection in the institute, syndromic approach to titrate duration of antibiotic. Know the antibiogram to choose appropriate empiric antibiotic. Good infection control and routine audit and antibiotic stewardship. Thank you.
Thank you, Dr. Sudha, for excellent talk. It is very informative and we need it. Probably you can answer questions from here as well. I have few questions. In your presentation, you mentioned about coagulase negative stuff being the commonest, but when I looked at the absolute numbers, it was around 26 patients and only 4 patients in that group were positive for coagulase negative stuff. Was it really indicative of some sepsis or is it because of possible contamination?
So, the coagulase negative staff in this presentation, actually, according to the ELSO registry, which was in 2008, the new studies and all actually says it's very less, 4% only. So that was my ELSO registry. But all the studies right now is showing that the cons are actually with less, the incidence rate are less with cons. So you're right.
And the second question is about ICU prevalence of organisms. We looked at various countries reporting the data from Korea and other countries, even in India as well. In my personal experience, I feel the flora depends on the ICU where you are and the clinicians' beliefs, practices, how they use the antibiotics, do they de-escalate antibiotics or continue antibiotics, and all those things. So what I mean is, a medical ICU is different from a surgical ICU to, so and so on and so forth. It depends on the practices in that particular ICU than saying a particular hospital has got this flora as such. Okay, many people start antibiotics, continue forever, and don't de-escalate. That's where I found is a change I want to bring.
So basically, sir, when we think of an infection, we need to always think about the source of infection. And if this is really a colonizer or if it is really an infection, that's also very important. Because if it is a colonizer, we don't need to treat. If it is the infection, source of infection, because if we know the source of infection, we know which antibiotic will penetrate, and based on how long the treatment is also based on that. And also the organisms, certain organism like Pseudomonas, we need a longer duration. Whereas Klebsiella and all, we can actually de-escalate in 4 days based on the procalcitonin level. And intra-abdominal infection, so the source, we need only 4 days. So we need to know what is the source, what is the organism, and also we can de-escalate based on the markers like procalcitonin and beta-DG if we have that facility in the hospitals.
Thank you. And prophylactic antibiotics as well, definitely we practiced what you told us earlier on. We used it for 24 hours to 48 hours and then stopped it. But in our country, people will be very, very twitchy to adopt that sort of protocol and would like to depend on antibiotic therapy for longer period of time.
It's definitely difficult to, but you know what, if someone is on 5, at least we can advocate and bring it to 3 days and then slowly to 2 and 1. So it's a long process that to make other person convince and de-escalate. Yeah.
Thank you. I know it is a very interesting topic. Vivek?
Just one comment on the interpretation of beta-D glucan in cases of any membrane, whether it's ECMO or CRRT, should be done very cautiously until we are sure about fungal infection, because there is a cross reactivity and we get a false positive results in the, especially for fungitum.
Exactly, sir. Beta-D glucan and galactomannan, they both are not a very great marker when it comes for diagnosis. It's basically to rule out.
Especially when we have a membranes.
Okay.
Because even the sampling technique is very, very important in beta-D glucan. If somebody is using cotton for swab purpose,
Exactly.
again that will come positive and that will be falsely positive.
Correct. Exactly.
Good evening, ma'am.
Just
I have
last question.
Yes, I have a question.
Yeah.
I'm Dr. Anand from Bhubaneswar, Some Ultimate Hospital. So, in secondary nosocomial infections are the most disturbing things for ECMO patients. I think in all of the hospitals doing ECMO. So, my question is, in one of your slides, you showed 48 hours after the antimicrobial should be stopped. So, in your hospital, do you do it? And what are the specific infection control policies at your hospital for ECMO? Any specific measures you have taken to decrease the nosocomial infections for ECMO patients specifically?
We do have a good HIZ practice here and antibiotic stewardship. We do every day round on our patients and make sure that if it has to be de-escalated, we discuss with the team and we actually have a dialogue and if needed, we de-escalate with the team meetings.
Like everyday rounds with the
Every day
ECMO
rounds I
team
have with the team
and
actually.
de-escalation of antibiotics.
Every day I have rounds with the transplant team and the ECMO team, and every patient individually we go through and see all the patient drugs, the dosage, or everything, creatinine clearance, excretion, and also the duration of, yeah.
Any specific, ma'am, or in all the centers, I think ID specialist may not be possible, ma'am.
No,
So what will be your take-home points to those hospitals? Microbiologists are there, I agree.
I'm sorry.
Microbiologists are there, but ID specialist, I think
Yes,
in
see,
all
actually
hospitals
we,
not possible,
I
ma'am.
have a clinical pharmacist also, so we
Okay.
train them. So you can train your clinical pharmacist as well, so that they can look at the antibiotic, the dosage, everything. Even they can help you out on this. And definitely the knowledge. The knowledge, if more knowledge is spread to the intensivist, and they can also take care of it.
Thank you.
Thank you very much, Dr. Sudha.